You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hello, and welcome to another episode of Fertility Docs Uncensored. I am here with my stunningly brilliant colleagues, Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
And Dr. Susan Hudson from Texas Fertility Center.
Hey, how are y'all?
Good. How are you doing? Are you surviving this weekend?
Oh, I want it to be next weekend at 3:00.
Most people don't want to jet through this weekend and jet through the subsequent weekend.
Yeah, well, I am taking an accounting class for my MBA. And all in all, I have really liked my accounting class. I think my professor has been one of the best professors that I've had my entire, I've taken 5 or 6 classes already, and he teaches and he has assistants who do all the supplementary teaching. I mean, really, I am smarter than I was 6 weeks ago.
That's important.
On this subject.
I wish I could say that.
This is like the home stretch. I have a paper due tomorrow, and I have my final next weekend on Saturday from 1 to 3. So that's why I want it to be 3:00. Realistically, I'm not too concerned about the final. You get to have 2 cheat sheets, front and back, has to be handwritten and stuff like that. But I mean, I'm like, the midterm wasn't too bad. I'm like, the final won't be bad, but the paper it's all these questions and you have to do all these calculations. And I got totally stuck on this one thing that I was doing last night. And apparently there's cool resources that were not available.
Can you use a computer or a calculator or anything?
You can use a calculator.
Oh, good.
Yeah. But on my paper, there's this question that honestly, I'm like, I have no freaking idea how to solve it. And then my internet went out yesterday because we had this big lightning storm. And so it was a big old hoo-ha. But there's these websites, and this one called Course Hero, where you get a subscription and it's essentially online tutors to help you.
Oh, that's cool.
So this made me feel a little better. So I paid my $40 for a 1-month subscription for this because I'm like, I only need it for the next 48 hours. And so I submitted my question. It's really cool. You put in all the information that you have about your question, and you put in what type of course you're taking. And so even mine, this section is managerial accounting. So it's different than financial accounting and,
oh, wow.
and things like this. And so on the thing, it says, average return time for an answer is 30 minutes.
Oh, that's cool.
I submitted my question and this made me feel better when I woke up this morning. So I submitted my question at 5:30. By 6:00, it was assigned to somebody and that person was working on it. They posted their answer at 1:30 a.m.
Oh my gosh. Was it the right answer? Do you know?
I actually had an egg retrieval this morning, so I haven't had a chance to look at what the answer is. So, but I'm the fact that it took the people who do this for a living
know what they're doing. Yeah.
That long, I was like, okay, well, that makes me feel a lot better. I'm accounting is knowing basic principles, and it's knowing which formulas to use for what circumstance.
Yeah. It's like statistics.
It is like statistics, but I think I like accounting more than statistics. I've never had a fond relationship with statistics, whereas accounting, I'm ooh, this could actually be helpful in some terms. And I definitely have a better grasp when I see a balance sheet and an income statement and all those things.
No one ever told me to take accounting in college. I wish I had.
Mm-hmm.
Oh my goodness. And the thing, it is kind of funny though, because, I'm taking this as master's level stuff, and I sit there and I'm learning this stuff, but I'm I sometimes wonder why this is master's level, because I'm this seems like the bread and butter of what you would be studying. And so I don't know. Of course, my only comparison is, you have undergraduate and you have med school for us. And it's interesting because I kind of want to be like, what do you learn in undergrad if this is what you're learning in your master's level classes?
Well, but it also may be geared, you're doing a healthcare master's, right?
But this class, my master's program, like you have a general master's program that's available for anybody. And then you have like, I have to take like 4 additional courses to make it healthcare focused.
Yeah.
But this is like part of the core curriculum of everybody.
You have to take prereqs so that they assume that you have at least some of the foundations for some of this stuff.
Yeah, I bet that's what they're trying to do is make sure everybody's kind of on an equal footing because
you do have prereqs. Like there's a basic accounting class that you're supposed to have before this.
But if you've taken that at age 20 and you're now age 40 coming back, you probably need a little refresher or something maybe.
Right. I don't know. It surprised me.
Well, I'll tell you, when I took my master's, which was not an MBA, but it was in clinical research. I mean, there's a class that I took on bioinformatics, which is all about genetics and all this genetic online stuff. And I mean, things had changed since I'd taken, a class that talked about DNA and RNA and messenger. I mean, the basics I knew, but there are things that changed. And I didn't have a class like that. So I was like going, what is he talking about? What's this stuff that he's talking about here? And so it's good that you had that though, because they're trying to get everybody on an equal level.
Yeah.
My complaint was they jumped too far for me because there was stuff that I knew from a long time ago that I didn't know now.
That makes sense. Anyway, I've enjoyed it. It's just, I want it to be next weekend.
Good news, it's about over with. So what about you, Carrie? What have you been up to this weekend?
Yesterday morning, I went out we have a deep freezer in our garage, and I went out to the deep freezer because I was going to get some, turkey sausage to make for breakfast for, family. And I get out there and I open up the freezer and I'm like, this doesn't feel right. And I have my arm brush against a loaf of bread and I'm like,
it's wet.
Like that is soft bread. That should not be soft bread. So it turns out we've got our trash bins, the big ones, right next to the deep freezer. And when they got put back, they knocked the plug loose.
Oh, shoot.
So, and then my daughter made the comment of, oh yeah, on Wednesday, we thought it felt a little warm when we went in there to get whatever it was she was getting. And I'm like, so the next time that happens, sweetie, you need to tell mommy and daddy. So
if the family won't get food poisoning.
So my husband and I spent yesterday morning unloading the entire freezer, figuring out what was okay, like things like bread, which, it was fully dry. It just had thawed. And then what was not. And so as a result, I had previously frozen sausages and made like a zillion pounds of sausage last night because I needed to. And I have a zillion pounds more because that happened to be the one thing that was super stocked on. It was like, okay, this make it.
You went to Costco and got a bunch of.
Yeah. Like I threw away a bunch of other stuff. Like I am not, I'm sad to lose it, but I am not getting food poisoning over this.
Yeah. Oh.
I got to tell you my favorite deep freeze story. So in my household, a deep freeze issue on average happens about every 18 months, which I personally think is actually the appropriate interval.
Makes you clean everything out.
It makes you clean everything out. But the biggest deep freeze story I ever had that was like, oh my goodness, was my husband had gone on a fishing trip to Alaska and brought home like all of this like fresh caught salmon and all this stuff. So needless to say, it was in our deep freeze. Well, the deep freeze, something happened at the appropriate interval. And it was like, I am not kidding. Like I had an unbelievable amount of salmon that had thawed.
Aww. So you had a feast?
Oh, that's sad.
Well, I'm like, there's only so many things you can do. I mean, we love salmon, but there's only so many things you can do with salmon. But I needed something that I could, I needed to fix like this massive amount of salmon for me to be able to like fix it, cook it, and potentially like refreeze the final product. So I fix like the largest amount of salmon patties you have ever seen in your life. Like we usually just bake our salmon or grill it or, something like that. But I had literally like, I can't even imagine, those giant stainless steel bowls you can get from IKEA that you like only pull out at Thanksgiving. Like we had more than one of those full of mixings for salmon patties. So it ended up being wonderful. It was a good like, ooh, it's kind of like when you're watching Chopped and it's like, what do you do with this?
Your version of Chopped.
Mm-hmm.
How's your weekend going, Abby?
It's going well. I'm playing at gardening. This afternoon, I'm going to meet with an older gentleman who's a master gardener, and I'm working on sort of a garden with he and some other people. So he's teaching me things. So we're going to plant some seedlings and see how our tomatoes are growing. And this weekend also too, I planted some petunias. So my weekend's been a gardening weekend, basically. We started having good weather now in Nashville. So minus a few extra rain, a little extra rain we've been getting, but it's been a good time to go out and garden and be outside.
Nice. Very cool. All right. So Susan, what question do you have for us today from our question bank?
Okay, so today's question is, I have had recurrent miscarriages and recently found out that I have a bicornuate uterus. However, it is not normal in shape. One of the uteruses is much smaller and is positioned behind the larger one, and my doctor believes it's too small to safely have a pregnancy and may be causing the miscarriages. My doctor suggested seeing a specialist to try and have the pregnancy in the larger uterus. What would that treatment look like? I'm having a hard time finding any information since my situation is so unique.
One thing I'll say about a bicornuate uterus is recently I had a patient that I did hysteroscopy on. It looked like she had a bicornuate uterus based on her MRI. And so I hysteroscoped her. And it was really interesting because one side was really large and the other side wasn't very large. And I thought, gosh, that's so strange. And then I started to remember she had had a baby before and actually had done well with her pregnancy. And so after we finished the hysteroscopy, when I saw her back in the office, I said, do you happen to remember which side you were pregnant on? And she said, yeah, it was the right side, which was the side I was looking on. And I hadn't thought to ask her that before I hysteroscoped her. But, if you've had a baby before, sometimes that can make the two sides of the uterus look a little different. So I don't know if that's the case with you or not. I don't know that there's any data. Well, I know there's probably not any data on, a big side and a small side. The uterus is pretty good at stretching. And, we know that having a uterine malformation is associated with miscarriage for sure. It's really hard to know. And I'll be interested to hear what Carrie and Susan have to say about this. But it's really interesting to think about whether or not being on a small side would be worse than being on a big side. I'm not sure that I'm not sure that I believe that personally. There's no data to really tell us that because the uterus can really stretch. And so, the bottom line is if you have a bicornuate uterus, it's really not fixable surgically. And you do have an increased risk of miscarriage. But, I've also had many people who've gotten pregnant with a bicornuate uterus and have done fine.
A lot of the time when I've seen smaller, one side of the cavity or one cavity that is smaller than the other, of course, with fertility treatment where we can actually direct where an embryo goes, for example, we err on the side of the larger one. But I would say that I've tended to see more preterm deliveries out of that than necessarily a miscarriage. Because with a bicornuate uterus, the physiology of the uterus is the same as a non-bicornuate uterus. So the lining thickens, it develops, implantation is fine. And so typically the first stages of pregnancy tend to go just fine, first trimester, oftentimes deep into the second and sometimes early third trimester. It's when you really start to stretch that you end up with more problems. So a bicornuate itself, unless there's something else going on, for example, if there was not just an incomplete fusion of the two halves of the uterus, which is what happens to get normal anatomy, but if there was a failure in migration of the endometrium so that the endometrium on the inside of one cavity versus the other is incomplete, that could potentially cause something. But it's a timely question because I've been up since 4 a.m. writing embryology lectures for the med students. So what do you think, Susan?
So first of all, I don't trust MRIs when it comes to diagnostics of a bicornuate versus a septate uterus. I have seen the MRI report be wrong more times than I would like to count. And so, kind of in this situation, I first of all think of when we study about what we call Mullerian anomalies, which are anomalies of how the uterus forms, when you look, if you Google Mullerian anomalies and you see these very defined, this is what a septate uterus is, this is what a bicornuate uterus is, this is what a didelphic uterus is, it seems very cut and dry. And what we have all learned in practice is there are variations in between each of those pictures that you can see. And so, when I hear this, I'm kind of, I'm inspired by kind of what Abby was saying is maybe you've had miscarriages, maybe the miscarriages have gone on long enough that side of the uterus is a little bit larger. And maybe we might actually have a septate uterus that looks kind of a little unbalanced. And especially as somebody who I'm not let's rush you to the operating room, but these types of situations that seem a little odd, these are definitely the type of situation that I think that often having a laparoscopy with a hysteroscopy at the same time, do we have a bicornuate uterus that actually has a more of a septum in between than the full muscle. So when we think of, as physicians, when we think of septum, we think of something that's generally fibrous. Okay. It's tough like celery versus being muscular like meat. Okay. And so, that's kind of where I'm thinking of is making sure we truly have the right diagnosis. Because if we have a septal component, then that, and I totally agree with Carrie, if we have true bicornuate uterus, then we should have muscle everywhere and not that fibrous stuff. But if we have that fibrous stuff, that could be a underlying factor.
Yeah. And that's where I agree. The MRI, I agree. Definitely the old school is you need to have laparoscopy and hysteroscopy. But I do think the MRI is helpful in those situations. And there's a lot of them, like you said, where it's really not as cut and dried as what you think. And so I've seen a couple of situations where there's a little dip in the top of the uterus. It's hard to know if it's dipped far enough to be called bicornuate. So it's really helpful, I think, sometimes with the MRI, and not every situation, but to see what's muscle and what's not muscle. That can be really helpful in terms of kind of planning what you're going to do surgically. And the one other thing I meant to mention before and forgot to is, the patient was saying that her doctor thought it was wise to see somebody so that they could place the embryo in the correct side. Big problem with that is, I think we like to believe that when we do an embryo transfer with IVF, that we place it in the best spot in order for it to implant. I remember being at ASRM a few years ago, and they showed a video of a woman who had been scanned with an ultrasound every, 10 minutes after she'd had an embryo implanted. And so she did this for like 3 hours. And so you can see the little air bubble that's released right before right before the embryo is released. And it was like Flight of the Bumblebees. You could see this little dot go all over the cavity. So unfortunately, we don't have glue, and we can't put the embryo in and glue it in the correct horn. So if the two sides are connected, unfortunately, there's really not a way we could guarantee that embryo would stay in that side. So
the only way that's possible is if you have uterine bicollis, which means you have two cervices, and we intentionally are putting it in the right or the left. But if there's, like Abby said, if there's any connection, that embryo is going to kind of end up where that embryo ends up.
And there's really, going back to the MRI issue, there's no substitute for an REI, like someone who does this
That's right.
those images and evaluating it and combining it with surgical findings. It's kind
of like the way we use ultrasound. We don't use it as the be all end all, but sometimes it can be helpful to plan for surgery.
Yeah. I think 2 weeks ago, I had a patient who was diagnosed with a septum on her MRI, where when I went back and was like, this doesn't sound right. And I looked at the pictures and I'm like, I don't think this is what it is. When I did her exam, she had a full vaginal septum. She had two cervices, two it was full didelphus.
Didelphic, which means two completely separate systems. Yeah. So you wouldn't have wanted to go in and operate on that patient.
No, that would have been a very bad day for many people.
Yeah.
So it's really helpful to go back and look at those images and really parse it out and go through it with partners a lot of the time, because I
usually call the radiologist and have them go through it, because I know our colleagues in radiology are very good, but the terms that they use sometimes are not the terms that we use. And so basically when I'm talking to them, I'm like, okay, here's what I'm looking for. Is this somebody I'm able to operate on and fix this problem? Or is this somebody I'm not able to operate on? And I think once you explain it to them, they can walk you through the MRI and go, okay, yeah, this is what I see here. And it really helps a lot.
Yeah. All right. So on to our topic of the day, which in my mind always goes in the sex, drugs, and rock and roll category. Even though we don't necessarily think of them as a drugs, what we're talking about today is alcohol and tobacco and how that impacts fertility. And it's important to remember that those, even though they are not, found on a shelf with a prescription on them, although some people I think maybe think of them as that, they're very much drugs because they act on receptors in the body. They impact some of the physiological processes that happen. And so in the same way that medication is a drug and drugs of abuse are drugs, alcohol and tobacco are legal drugs that you do not need a prescription for that can impact everything that happens in your body. So we're going to kind of go through some of the things that we know and that we don't know about them. What do you guys want to start with? Tobacco? You want to start with alcohol? Let's
talk about with tobacco, because I think we're probably all very much on the same page about tobacco.
Okay.
And I would like to say, let's discuss nicotine and not necessarily tobacco.
Oh, good idea, Susan. I like
We're
that.
We're talking to all the vapors and the people are using patches and gums. It doesn't matter if you're just smoking it. It's nicotine.
Yep. Chewing tobacco applies as well.
Yes.
Like all the e-cigarettes, vaping, that's something that we actually get pretty commonly. My patients laugh at me a lot whenever I ask this particular question, because I'll ask, okay, do you smoke? Do you drink alcohol? Any other drugs, including e-cigarettes, vaping, nicotine patches, tobacco, marijuana of any type? And it just gets rattled off so quickly that they're like, I've asked this before. And I'm like, yes, I have. Because I
worked in Las Vegas.
Not even that. I got burned
it's anywhere.
Like it is everywhere. And you only have to get burned by that once as a doc to never make that mistake again.
Yeah, tobacco is probably the number one cash crop in Tennessee. So yeah, we definitely see a lot of that.
Okay. So how does nicotine affect... Let's break it up into two phases. Let's talk about before you get pregnant and when you are pregnant. So the part that's been studied really well is when you are pregnant. So let's start with that because that's a little more clear cut. So what do we know about nicotine use in pregnancy?
So we know that nicotine use in pregnancy does affect things primarily when we're thinking about things related to some sort of vascular supply. So you can end up having placenta issues, which can increase the risk of miscarriage. It can increase the risk of having small babies. It could increase the risk of you having to have your baby early because of bad things. And increasing the risk of high blood pressure issues like preeclampsia or eclampsia.
Well, and it can increase the risk of SIDS deaths too. That's the other really, really scary thing as well. And, what it really does is it's almost like when you smoke in pregnancy, you're essentially constricting your baby's nutrients and blood supply. You're giving the baby not everything that it needs. And so it's kind of like a seed. If you only water it once a week and it needs to be watered every day, it's not going to grow as well. It's not going to do as well. And if you don't water it enough, it's not going to make it. And so that's kind of really the analogy with smoking, I think.
So is there any hierarchy of better to worse that we know of? I mean, if you're faced with smoking cigarettes versus chewing tobacco versus nicotine patches versus vaping, I mean, is there a lesser evil among them?
I don't think there's actually necessarily strict data to support this, but I would say that the pure, this sounds really bad and I hate to be saying this, but like I would rather have you just exposed to nicotine than all those other chemicals that are in tobacco products.
A lot of carcinogens in the smoke. Yeah.
Right. But I'm not condoning it in any way, shape, or form. And we want you to be using the least amount possible. So, I would rather you be smoking 2 cigarettes a day than 10 cigarettes a day, but I'm not going to be happy about 2.
Mm-hmm. And I would be using a nicotine patch instead of smoking. But same thing, I'm also fully aware that nicotine is going to directly hit the nicotine receptors, which are all throughout the body.
Yeah, the one thing about nicotine patches or gum or whatever, the nice thing about it is you can control the amount. So if you're really somebody that's really trying to quit, you can say, okay, well, I'm doing better this week than I did last week because have less nicotine exposure to the baby. Whereas smoking, you can't really control that as well. I mean, I don't know how much regulation there is in terms of the amount of nicotine and carcinogens from cigarette to cigarette. I mean, maybe there's not a lot of variability, but still, like Susan said, you get a lot of other crap from cigarettes, from the smoke itself, that you don't get from the nicotine patches.
And secondhand smoking effects are real. I mean, when I'm screening for example, gestational carriers and egg donors who, when they come through our office, they get really thorough. We follow all the FDA guidelines, of course. And one of those guidelines is to check them for nicotine and cotinine, which is a metabolite of nicotine. And we definitely have patients who come through who, swear up and down they're not smokers. And when we say, well, your test came positive, and they're like, well, I live with grandma and she's a 2-pack-a-day smoker. And so as soon as they move and we see the change of address come through and we retest a month later, there's a difference. So, that you never know what's true and what's not, but I have seen that consistently enough where, to the extent that you can avoid secondhand smoke, I would.
And so when we're talking about like tobacco and alcohol, we are going to address both men and women. And so that's one reason why when we're talking about baby wise, that secondhand smoke is very, very important. And we know that, children with people who smoke in the household have increased health issues, including asthma and things like that. So it really can have a long-term impact.
I think sometimes when you live with a smoker, even if you're not a smoker, you sort of become numb or immune to the smell of smoke. And so I will tell you kind of a funny story I was thinking about when you said that, Carrie. Several years ago, we had a couple that came to see us, and they brought their consents on paper to us in a manila folder in a packet. And one of my IVF nurses was very good about really kind of, asking people if they smoked. And, the female partner said, oh, no, I don't smoke. And, she was very adamant about telling them how bad smoking was. Well, when she got the manila folder and she opened it up, and it really reeked of smoke. And so she kind of, really kind of gave them the riot act about smoking. And I think they left and they were not very happy with us. But even though maybe the delivery might not have been the way it should have been, I think in the long run, my nurse's heart was in the right place. She wanted to really let them know how negatively it can impact their fertility success.
So kind of on that note, what impacts does it have kind of preconceptually, both for men and women?
So preconception, and it can have, let's start with women. We know that this is one of the more known, more definitive factors that can impact ovarian reserve. And of course, it has a negative effect, because if it had a positive effect, everyone would be screaming that from the rooftops. But it's a long-term smoking history is more associated with decreased ovarian reserve and decreased egg quality. And so that's part of the reason why when we're going through your history, we're looking for that information.
So Carrie, why is a hit to ovarian reserve a big deal?
Because ovaries start with all of the eggs that they're ever going to have. You get, when you're still in your mom's belly, you have roughly, 6-7 million eggs. And then by the time you're born, it's about 1 to 2 million. By the time you hit puberty, it's 300 to 500,000. By the time you hit menopause, it's a couple hundred to 1,000. And so if you do or experience anything that cuts into that set of numbers, there's no going back. So, for example, when people have chemotherapy or surgery that really knocks out the number of eggs that are available, there's no getting that back. So when you're doing something that is more voluntary, like tobacco usage or nicotine usage, that's knocking out that egg reserve, we don't have any way to go back and recoup that to help out a couple.
I was going to say, I would suffice it to say too, and this is just anecdotal, generally if I see women in their early 30s, I don't see as much impact with smoking unless they're big time smokers. So recently I saw somebody that smoked 2 or 3 cigarettes a day, which I think is kind of a big time smoker. And we did her AMH and it was low and she was in her early 30s. Beyond about age 37, if somebody's a smoker, it's really rare. You're laughing at me, Susan. Why are you laughing at me?
You consider 2 to 3 cigarettes a day as a big smoker?
Well, it is when you've never smoked before. I think that's a big smoker. But I was surprised that even, with that number, she smoked every single day for a long time. It had an impact on her fertility. By about age 37, if somebody tells me that they were a smoker at some point or a current smoker, I'm almost expecting their AMH to be a little bit either borderline or abnormal, because it really, I feel like, has a big impact on women, over the age of 35.
And just to kind of give people a perspective, there's a couple of other things I want to talk about. But, when we do egg retrievals, we can feel like there's a feel of what a smoker's ovaries feel like. Okay. When we do an egg retrieval and the needle goes into the ovary, it should essentially, under the best of circumstances, just kind of slide in like butter. Okay. And there are, I call them smokers' ovaries, and they are hard. They're tough. It's hard to get into the follicles. It's definitely affected the tissue. And kind of along that note is that when you are an active smoker, that byproduct of nicotine that Carrie mentioned earlier, that cotinine is actually in the follicular fluid, the fluid that's bathing your eggs. And the nice thing is when you quit smoking, that can get cleared out of that follicular fluid. And it's going to give you better chances of getting pregnant. I think most of the studies are done in IVF cycles, but using nicotine can decrease your chances of success with IVF up to 50%. And that's huge. So when you think about the cost of those, whatever your nicotine source is, that makes for really, I don't think anybody would choose to cut their success rates in half for IVF under any circumstances.
All right. So what about nicotine usage in guys? What do we know about that?
So we definitely know that it impacts the chances of sperm fertilizing, perhaps increases the chance of things like DNA fragmentation.
Mm-hmm. We know that the metabolism of all of the tobacco products, a lot of that is the body gets rid of it through the urine. And particularly in men, the path that urine exits the body is some of the same path that sperm exits the body. So anything that's going through that's leaving behind negative metabolites and chemicals, if it's on that road traveling through the urethra out the penis, the sperm travels that same track. So anything that goes through with urine can be picked up by sperm and have a negative impact.
And true, this is not fertility related so much, but with women, same sort of deal. If you're a smoker, you have a much higher risk of cancers of the female reproductive tract, of the vulva, and et cetera, for the same exact reason. And we know that also, kind of as Susan was saying earlier, that basically if you're exposed to those toxins and nicotine, causes oxidative damage to sperm. And it's harder to measure because we can't really look at the sperm before we put it in the egg, but it probably is causing some damage to the sperm.
Yeah. All right. Let's talk about alcohol. So start with the straightforward, more information stuff. Alcohol in pregnancy, how much is safe?
We do not know how much is safe. And that's the reason in the United States, we essentially say no alcohol during pregnancy. In other countries, they don't necessarily have those same guidelines, but we don't have a measure of how much alcohol is going to lead to things like fetal alcohol syndrome.
Mm-hmm. So pretty clear-cut data there. No amount is safe.
Don't drink
to use in pregnancy. So don't recommend that at all. How about when you're trying to get pregnant? What kind of effects can alcohol have on the male and the female reproductive systems?
I was going to say on the males, I forgot what one of my mentors used to say, but it doesn't affect the sperm so much as it affects the performance of the male, i.e. erection. They have much more difficulty with erection if they're, drinkers.
What I tend to see in men is men tend to be more binge drinkers than being people who drink all week long. Granted, there are still some people who drink all week long, but I would probably say 20% at least of the men that I see admit to what I would consider binge drinking on weekends. And the people who do that to excess, I predict they will likely have a hit in their sperm And it can be pretty significant. It can be pretty significant. We know that high alcohol intake can decrease testosterone levels, innate testosterone levels. And if your body's not innately producing that testosterone, it's not going to produce sperm effectively, thereby affecting sperm function.
As a secondary to that too, people that are big drinkers can gain weight. And sort of the same sort of thing, increased weight can also increase your estrogen level as a man and decrease your sperm count.
There's an old joke of, well, how much drinking is too much drinking? And the joke goes, it's however much more than your doctor drinks.
Kind of like smoking, right? That's the joke for me with smoking.
Exactly. It's however much is more than what your doctor does. But there's actual definitions. So binge drinking is for women, for men, 5 drinks on more than one occasion within a couple of hours. Heavy drinking for women is considered like 8 or more drinks a week. For men, it's about 15 or more drinks a week. That's really just 1 drink a night, 2 drinks a night, depending on if you're male or female. And there's definitions of how much a drink is. I mean, depending on whose house you're at, and you have a glass of wine, sometimes it's a 3 to 4 ounce pour. Sometimes it's an 8 ounce pour. And so,
you mean if it's in one glass and it just never empties, that's not just considered one serving?
Sorry to break your bubble, Susan, but
so that's something that's actually worthwhile. Like if you don't know how much you drink and you can't easily quantify it, it's probably worth going to some of those, just actually measuring out like, okay, if I pour this much wine in my glass, how much am I actually drinking? Because especially in some of the big red wine glasses, you can get quite a bit more than you think you're drinking. Like, oh, it's just 1 glass of wine. Well, in reality, it might be 2. It might be a little bit more than that.
Wine glasses have definitely gotten bigger in the last 10 to 15 years than what...
Everything's gotten bigger. Plates have gotten bigger. Glasses have gotten bigger. Mugs have gotten bigger. Yep, absolutely.
Size always matters.
Well, and it goes back to weight. Again, if you're drinking a glass of wine, that's 300 calories that you probably don't really need. And if you drink a glass of that a day for 7 days, you're going to gain a pound of weight. So same thing for women. The more they drink, the more weight they're going to gain potentially too.
And alcohol has an impact on the gonadotropins, the LH and the FSH, that those are the hormones that it takes to make sperm and to make eggs mature. And so if there is something messing with the system, that is going to mess with your ability to get pregnant. And so we typically tell people to be really mindful of what they're drinking. And there's the caloric component of it. There is the hormonal component of it. There's the emotional component of it, because alcohol is a really good sedative. And a lot of people use it for dealing with anxiety. Same with tobacco. So when you all of a sudden increase or decrease the amount that you're intaking, your emotional stability takes a hit because you are changing the drug that you're taking for it. You might not be getting a prescription for Prozac, but that glass of wine is a prescription of sorts.
Mm-hmm.
And I don't want to diminish any of it. Like I love alcohol and wine and all those things. Like I love good tequila, all of those things. But you really got to be mindful of what you're drinking and when, because it is a drug like anything else is.
Mm-hmm.
And one thing that I advise my patients, the female patients, is that essentially from the point that they ovulate, they are pregnant until proven otherwise.
Yeah.
If you are trying to conceive and you have ovulated, like that is like, you should treat yourself and your body, the temple that it needs to become for that little baby to develop in the best shape that it can.
Anything else to add about tobacco, alcohol, anything like that? There are lots of good hotlines out there if you think you may have a problem or someone that you're with may have a problem. There's lots of good techniques for quitting smoking. There's some medications out there that are really helpful. All of those things are important when you're thinking about quitting. So you've got the support to make it successful. Any good doc is going to be a cheerleader in that and help you. Even if they don't have those resources right at their fingertips, they can help you find them. So
Well, and I think improving your fertility is one of the best motivations that you could have for, for quitting smoking and for, decreasing your alcohol consumption for sure.
Yeah.
I always say that, all the other reasons why you should not do these things. These are the good reasons. And, there's something very positive to look forward, not just like, oh, we're going to prevent heart disease and things like this, but we're going to hopefully make a baby.
Cute little baby.
All right. So to our audience, thank you for listening, and be sure to tune in next week for more, and be sure to subscribe and leave us a review in iTunes. We'd love to hear from you.
You can also visit fertilitydocsuncensored.com to schedule an appointment with any of us or submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for the Ask the Doc segment. Don't hold back. We love your questions. We love your ideas for new programs.
All right. We'll talk to you soon.
Bye.
Bye, everyone.
Bye.